Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome. We've got a special guest here to discuss his take on what he thought was the best of ASCO 2024 for melanoma and skin cancers.
And Jeff Weber needs no introduction, but Jeff's a medical oncologist treating melanoma, deputy director of the Laura Isaac Perlmutter Comprehensive Cancer Center, and professor of medicine at NYU Grossman School of Medicine. So welcome, Jeff, and thanks for being our inaugural guest.
Thank you. Pleasure to be here.
Jeff, we were thinking maybe just a couple of quick background questions. Where did you grow up?
I grew up in Brooklyn, New York.
New Yorker, but you have been all over the U.S. Do you remember all the places you trained and have been in practice?
Well, yeah, I guess I've shuttled back and forth between the coasts. I went to college at Columbia, which is, of course, in New York City, and then went out to California for a couple of years to work. And then I came back to NYU to be an MD PhD student. Actually dropped out of the MD PhD program to do my PhD at the Rockefeller, which is also in New York City. And then went back to the West Coast to be a house officer at UCSD. Came back to New York, bizarrely enough, worked as an ER doc at Bellevue because I just didn't want to go straight through the academic mill and do fellowship and faculty all at once. So I worked for a couple of years as an ER doc in New York. And then went to Bethesda to the NIH to be a medical oncology fellow. Worked in Steve Rosenberg's lab, became a staff member, which is the equivalent of an assistant professor. Then went back to the West Coast. I was at USC, University of Southern California, for 13 years. Rose through the ranks, became a professor, moved to Moffitt to head up a research center, was the principal investigator of their SPORE, their multi-project grant in melanoma, and then came to NYU, where we also have now a SPORE. That's me and Iman Osman are the co-directors of the SPORE, and I'm also the co-director of the K-12 mentoring program.
Jeff, that's incredible to say the least, and I think you're probably packed with a lot of stories in the Bellevue ER for another.
Boy, do I have stories.
We're going to plan that Duke's bar, for you, and we're going to hear those stories in London one of these days.
Absolutely.
Okay. Incredible. So just to get into ASCO a little bit this year, if we may, Jeff. So I guess, would you better perhaps quickly summarize the update for the V940, which you presented, and then maybe supplementary to that from me, couple of questions. One of which is, we really not seeing any kind of new tox signal there, given this is a new therapeutic, I guess, in humans. And then my other sort of broader question on that would be, at the moment we're talking about the adjuvant setting. Do you think that kind of strategy might have some reach into the metastatic setting, say with low volume metastatic disease or similar? So over to you.
Sure. To refresh your memory, V940 or Keynote 942 was a randomized phase 2 trial, one of my favorite designs, of 157 patients who 2-to-1 received a randomization to either get a personalized mRNA neoantigen vaccine with standard pembrolizumab versus pembrolizumab alone, 2-to-1 randomization, which I think for patients is a bit of a selling point. And it was an adjuvant study in stage 3B, 3C, 3D, and 4 resected melanoma by AJCC 8th. So contemporary staging. There were essentially no 3Bs, it was all 3Cs, Ds, and 4s. So this was a high-risk population. And at the interim analysis, which was about 2 years of follow-up, a little over a year ago at AACR, I presented the initial data showing a benefit in terms of recurrence-free survival, but the two-sided p-value was 0.052. Subsequently, there were data at ASCO suggesting a distant metastasis-free survival benefit for the combo versus standard pembrolizumab, with a p-value of about 0.018 or something. And now we have 3 years of follow-up, and a couple of days ago at ASCO, I presented the follow-up data. Over time, the RFS curves have widened a little bit, with an absolute difference of 20 percentage points, which is not trivial.
Yeah.
And the p-value two-sided is now 0.019, so it's quite respectable. The distant metastasis-free survival benefit is maintained with a p-value of about, I think it's 0.015. And the hazard ratio for recurrence-free survival improved to 0.51, reflecting a 49% reduction in the risk of recurrence or death with the combo versus Pembro alone. And distant metastasis-free survival hazard ratio is about the same. I think it's a 62% reduction in the risk of recurrence or distant metastasis-free survival or death. So the data are looking good. And now we have survival data. Interestingly, relatively few deaths at 3 years, which is typical for this population, thank goodness. But I think it was 96% versus 90% rate of death with a hazard ratio of about 0.42 or 0.43. Again, it's an exploratory endpoint. There's no real p-value. But if those curves continue to come apart, I think we're going to see a real survival benefit, say at year 5, for vaccine plus Pembro versus Pembro alone, which I think will clinch the idea that this is really beneficial. And as you all know, there is a large randomized study that's accruing like gangbusters.
Mm-hmm.
It's going to be about 1,100 patients. And I think it'll finish accrual in August or September or something. It's just incredible. We've barely been able to get patients on the trial because it's accrued so fast. So it's obviously a good trial. Exact same design as Keynote 942, randomized, blinded, 2-to-1 randomization, Pembro vaccine versus Pembro alone. And that will provide, I hope, the definitive evidence that there's clear benefit in RFS and DMFS for the combination versus Pembro. So I think that will be a new standard of care.
Jeff, I'm a little nervous, though, about that confirmatory design because, as you mentioned, the study that you've been presenting was this kind of higher risk 3 population, stage 3. And I think that the confirmatory trial is taking these kind of clinical stage 2s. Is vaccine necessary there? I don't know. I mean, I think the rationale for the 2s makes sense because they have a recurrence-free survival that approximates stage 3B, but it could water down some of this effect. I'm a little bit nervous that the populations
it could put off the number. I guess I think it's an event-driven interim analysis, so it could put it off because obviously a 2B has a better outcome than a 2C, a 3B, or a 3C. But I think the basic underpinnings theoretically should hold true. I see no reason why a 2B, 2C should not benefit from this approach.
Yeah. Your lab had that poster of flip-dose Ipi-Nivo Toci. What do you see as the future there? It looked great. It looked great as far as toxicity and, of course, efficacy as well. What do you see as next?
Well, Toci is coming off patent. So I don't imagine there'll be a huge enthusiasm for Genentech to pursue any sort of randomized study. As you know, we're now doing Ipi-Nivo-Rela with or without Sarilumab, which is a different, perhaps a little more potent IL-6 receptor blocker. And that's an interesting design. It's a 2-stage design. Not a Simon 2-stage design, but a 2-stage design where you treat 33 patients in the first stage to get a gut feel for the response rate, the PFS, the toxicity. And we've accrued all 33 patients in the first year between us, Angeles Clinic with Omid Hamid, Dana-Farber with Steve Hody, and Ryan Sullivan, who just came on at Mass General onto the trial. So, it's only early days, but I would be confident that we'll be able to reproduce the data that Paulo presented at ASCO for Checkmate Relativity 048. And I would say there's a very good chance we're going to reduce the side effects. In Paulo's study, he had a 39% rate of grade 3-4 IRAEs. That's kind of pushing it. I think that as time goes on, tolerance for toxicity with immune agents is going to drop a little bit. And I think any strategy that'll decrease toxicity will be welcomed.
Yeah, great.
Will there ever be a randomized phase 3 definitive registration study if our phase 2 data pan out? I don't know, but if there's a big enough randomized phase 2, that may make its way into NCCN guidelines. And I think if the data look good, let's say we drop the grade 3-4 IRA rate to 20% from 40%, just for the sake of argument.
Yeah, that's Nivo
I think
relevant.
that's good for patients.
Yeah.
And right now, if we can match the 59% response rate and the 2-year plus PFS of Relativity 48, I think we're going to be doing pretty darn well. Again, it's early days. After we treat 33 patients with all 4 drugs, we randomize 36 and 36, which brings us to 105. That's a big phase 2 study for an IST. This is not a pharma trial. This is an IST. Yeah. And while Regeneron and BMS provide the drugs, and BMS is pretty much paying for it, we're going to have to use institutional monies to finish the trial. And if the randomized portion looks promising, obviously 36 and 36 are small numbers, but we're looking for a hazard ratio of 0.5. To see that, I would hope that either the cooperative groups or pharma would spring for a phase 2 randomized study.
Yeah. So I guess the other big thing to talk about really is NADINA from ASCO. We chatted about this, I think, a couple of 3 weeks ago, Jeff, before the data had been presented, although I think you had an idea at the time, shall we say. So maybe just a really quick summary of that. And then my question is going to be how you think it stacks up against S1801 in as much as one might be able to make those comparisons and without offending Dr. Patel, obviously.
Well, NADINA, definitely one of the worst kept secrets in oncology. No question, this, and let's face it, guys, the fact that it's a plenary at ASCO, which we knew weeks ago, means it's not going to be a negative study. It's going to be a positive study. So, I mean, the data look pretty darn good. To my surprise, I believe, and again, correct me if I'm wrong, guys, but I think we only saw the event-free survival data, which looked very promising, very statistically significant. And we're not talking huge numbers of patients. I think there were only not even 500 patients on this study. And again, remember, it was kind of sliced and diced into small cohorts, meaning if you had less than a 50% PCR, pathologic complete response, and you were BRAF mutated, you went on to dab-trem. If you were BRAF wild type, you went on to adjuvant nivolumab. If you had a 90% PCR or better, you didn't get adjuvant therapy. So, it doesn't exactly answer the question of whether adjuvant therapy would be useful after a major path response or not. Now, Georgina argued at the session on Monday that, well, if with careful pathologic staging, nobody's relapsing at 3 years or whatever, it doesn't matter whether you give adjuvant therapy. If they don't relapse, they don't relapse. NADINA was an impressively done, impressively carried out, and impressively interpreted study. But we're missing a lot of data, and there's only 9.9 months of follow-up. So while it reinforces the data from Prado and Opus and Neo, I think the definitive proof that you can give 2 cycles of flip-dose-ipi Nivo, get an MPR, and do nothing further, really should await more follow-up, say 2 or 3 years. We go to 3 years, and you're seeing, a 98% RFS rate. You got me convinced. No one's going to argue.
Yeah.
I'm not so sure that'll be the case, but we'll see. Yeah. I think a little caution is called for, but I'm very impressed by the data. And I put my money where my mouth is. I've been using flip-dose-ipi Nivo neoadjuvantly for years, several years, 3 years at least, ever since Opus and Neo. So, yeah, I think this will be a standard of care. Now, that being said, we have to be a little careful because the definition of event-free survival in NADINA is different than in 1801.
That's right.
And somebody, a statistician, needs to put some effort, and we should take them away from torturing me and put their effort into adjusting for the difference in EFS definition in NADINA to see where the RFS curves at a year landmark or 18 months landmark, would be for 1801 versus NADINA. We're not talking a huge difference here.
Yeah.
So it's going to be close. But again, you're only looking at not even 10 months of follow-up.
Yeah. There may be something that I've seen Christians say before, which is the biomarker that seems to predict is baseline interferon gamma. And majority of those patients at baseline are high, at least in the OPASA Neo and Prado cohorts, such that maybe they get by with single agent PD-1. But there's a good portion, a quarter, a third that are interferon low that might need this combination. And then even a portion that need more than just doublet. So that'll be interesting. Maybe the last question, because I know you have to wrap here. Jeff, we've heard you a couple of times now. I heard you say it at AACR and again this year of where you think the personalized vaccine, the individualized neoantigen therapy could actually fit in a neoadjuvant strategy. Do you want to?
So as you know, there's V940-007, which includes the strategy with Pembro neoadjuvantly, but that's resectable squamous cancers.
Mm-hmm.
If someone has high risk, palpable, clinically detected melanoma, I don't think you can afford a 9 or 10 week interval of doing nothing that easily.
Right.
I think patients will balk. So I'm hard pressed to believe, unless we can really speed up the prep of the vaccine, to see how you could use it neoadjuvantly. That being said, I like the idea of doing two things. Everybody gets neoadjuvant, either Pembro or Ipi-Nivo, excuse me. And then after surgery, you randomly allocate to vaccine Pembro versus Pembro. Now, you're only going to be able to get away with that while V940-001 is not mature. If it matures and it's positive, nobody's going to go for that.
Right.
So it's a little awkward. And as you know, I've pushed for the neoadjuvant cohort of V940-001 for a year. And the problem is the FDA would not accept it because they don't yet think that neoadjuvant therapy is standard of care.
Right.
Go fight City Hall. I don't know how you can get around that. I also, just to wrap up, like the idea of taking a patient who gets stable disease or a PR, say after 2 12-week cycles in metastatic disease, and as durvalumab has been approved in non-small cell lung cancer, randomly allocating to the patients with metastatic disease who are stable and in a PR to get further PD-1 with vaccine versus just further PD-1 in maintenance. And I think that has promise because a lot of those patients will progress and their PFS is your endpoint.
Yeah.
So that's the one scenario in metastatic disease.
Yeah, well, that's great, Jeff. Gets us right back to the start of our discussions. Thank you so much for spending time with us, giving us your thoughts on ASCO 2024. Great meeting and great to see you as well. And I think we need to call it a wrap.
Great. Thanks very much. Thanks for having me.